Are we ready?
Yes, sir. Yes, sir. 1 minute.
How many people have joined?
Almost 50, sir.
Okay, I'm ready. You tell me when.
Yes. Dr. Santosh?
Yeah. Yes, sir.
I will introduce our Dean, sir.
Hello, sir.
Dean, sir.
Good afternoon, Dr. Santosh. Good afternoon.
Yeah, good afternoon, sir. Good afternoon.
How are you doing,
again, sir?
Yes, sir. Thank you so much.
Yeah.
Thanks for sparing your time to be with us here today.
No worries, sir. My pleasure.
Thank you so much.
In 2 minutes, we'll start, sir.
Yeah, no problem.
Sure.
Good afternoon, respected Dean Sir, faculty members, consultants, and all postgraduate students. I welcome you all on behalf of Department of Pathology, Symbiosis Medical College for Women, and Symbiosis University Hospital and Research Center for this guest lecture on prostate oncopathology, the story of Gleason grading from past to future, by our esteemed guest speaker, Dr. Santosh Menon, sir. I now request Dean Sir to give the opening remarks.
Good morning to everyone. As the Dean of the Medical College, it is my privilege to welcome you all to this afternoon's guest lecture. I especially welcome Professor Santosh Menon, Professor of Pathology, Tata Memorial Hospital, Mumbai. So we are indeed honored to have you with us today. I also wish to place on record my congratulations to the Department of Pathology, who have been taking this wonderful initiative of organizing regular slide seminars and guest lectures with almost clockwork-like frequency. And I'm really happy that you are putting in a lot of effort into this particular aspect of education. And I'm hoping that you will continue this wonderful initiative in future also. Now, today's guest lecture is on prostate oncopathology, the story of Gleason grading past to the future. With the advances in cancer diagnosis and treatment, we all know that a proper and a complete histopathology report is very, very important, for which, of course, a complete grossing is also very important. I'm sure that you will find today's guest lecture extremely useful, informative, and a professionally enriching experience. With these few words, I once again welcome you all to this guest lecture, this afternoon's guest lecture. Especially welcome Dr. Santosh Menon. Thank you, sir, for sparing your valuable time to be with us today and enlighten us on this very important aspect of the prostate oncopathology. With that, I wish you all the very best. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, respected Dean Sir, for your opening remarks. I take this opportunity to introduce our esteemed guest speaker, Dr. Santosh Menon, sir, Professor of Pathology, Tata Memorial Hospital, Mumbai. Dr. Santosh Menon, sir, has done his graduation from Calicut Medical College, Kerala, and has done his post-graduation from a prestigious postgraduate institute of medical education and research. He's been working in the field of genitourinary oncopathology since last 15 years. His few of the researches include gene translocations in prostate cancer, staging, system validation, and risk stratification in penile cancer, studies on specific variants of urothelial cancers, and grading system updates in renal cancer. He was invited to the editorial board of the 5th series of WHO classification on male genitourinary system. He is a nominated member of Genitourinary Pathology Society USA Membership and Diversity Committee. He is also a member of Core Committee and organizer for the development of first Indian prostate cancer consensus guidelines. He has been awarded for best paper presentation titled Role of Laminin and Fibronectin in the Genesis of Renal Dysplasia at the 52nd Annual Conference of Indian Association of Pathologists and Microbiologists held at Bhubaneswar in 2003. He has also been awarded for the best poster presentation titled Spermatocytic Seminoma, Clinicopathology Case Series from a Tertiary Oncology Cancer Institute in India at the London Europathology Conference in 2014. He has been conferred in 2015 the Travel Brusserie Award by the European Society of Pathology for attending the European Congress of Pathology. He has been part of several studies on prostate cancer pathology, including studies on digital imaging in prostate cancer, translational studies, and clinical trials. Now I request Dr. Santosh Menon sir to start the session. Over to you, sir.
Thank you, Dr. Vivek, for that very kind introduction and very lengthy, elaborate introduction. Thank you, Vijay Sagar sir and Dr. Anand and his team at Symbiosis for having me here today evening on a Saturday afternoon. So I'll quickly share my screen, if I can, just a second. Is my screen visible?
No, sir. Yes, sir. Now it's
visible. Yeah.
Yes, sir.
Yeah. So I begin by wishing each and every one of you at Symbiosis, as well as the participants, a very happy New Year. And hopefully this year we are going to do away with this virtual meetings in the coming months, and we may hope to meet each other by second half of this year. So with that, I would like to start by starting an ethical disclaimer that this presentation has some images, smileys and cartoons from the internet, which is solely for the purpose of education. There are certain images for the humor, but no way disrespectful to the patients, and there is no breach of confidentiality of any patients in this presentation. So when Dr. Anand asked me, what would you like to present? I quickly told him that we will probably discuss Gleason grading. There have been several changes over the years, and it's been quite a long journey of Gleason grading from 1966 to the current era. And in the future, we hope to see that we are going to change, if not the grading, there is integration of grading with a lot of molecular pathology in the coming years. So the talk would be pretty basic, except for the last part where we would discuss a little molecular. The idea is to involve the PG students as well as practicing pathologists, where we all identify with each other the problems which we face in day-to-day practice of Gleason scoring. But again, would like to highlight on some pressure points and some important aspects where the clinical decisions are based on pathology reports and pathology Gleason grading. So those would be the highlight of this presentation. It's a very general presentation, and I'll take you through this. So again, I'll put within this topic, I'll want to emphasize the role of pathology and pathologists in prostate cancer, the current and future directions. So we have been doing this Gleason grading for donkey years and long decades, many decades. But currently there are certain changes which are happening. It's difficult to keep pace with these changes. And in future, pathologists will get integrated and into a lot of molecular genomics and genetics, and form a liaison officer between the basic scientist and the clinician for individualizing patient management. And that's what I'm going to bring forth to you here. So as we know, the basic diagnosis of prostate cancer is based on digital rectal examination and serum PSA. So in general, if you look at it, most of the patients would be elderly patients who walk in with lower urinary tract symptoms. The urologist would put in a finger and check with the digital rectal examination to look how the prostate seems, whether it is firm, hard, whether it's nodular, right side, left side. They would check everything. They would check the rectal mucosa over the prostate, and then they would order a serum PSA in LUTS patients. Sometimes these findings may not be very confirmatory, and then they may need a biopsy. So there have been studies which showed that if you do only a PSA, 18 to 20% of prostate cancer would have been missed. And only a digital rectal examination for a prostatism patient would have missed approximately about 45 to 50% of the cases. And hence there is a need for doing prostate biopsy. So this is how a prostate biopsy is done. It's a transrectal ultrasound guided biopsy. So the gun is put through the rectum. The radiologist palpates it, and through the suspected areas, they do the prostate gun biopsy or the needle biopsy, putting the ultrasound probe through the rectum. Basic understanding about prostate is that you can have 6 core biopsies, which was done previously. Now, almost all the institutes have a standard 12 core biopsy template, which they use to send the biopsy needle sample, 12 core biopsies. So they are taken 3 from right, 3 from left side. And in a case of 12 core, the 6 from left side and 6 from right side, including towards the base and apex and the mid portion of the prostate gland. An important thing which as pathologists, as clinician, you need to understand that these core needle biopsies may completely miss the tumor. So the red ones depicted here are the tumor, and your needle may go through different areas of the prostate and completely miss the tumor. So this is just a random sampling, and each core of prostate samples only 1/1,000,000th of the gland. So there is very likely possibility that you might miss prostate cancer on needle core biopsy. But in general, the understanding about prostate cancer is that even though it is multifocal and it may be throughout the gland, small tumors may be there. The issue is that if it is a significant cancer, clinically significant cancer would be picked up by a core biopsy in most of the cases. And that's the idea of doing this random sampling in patients of prostatism with raised PSA levels. Again, a picture to show that the gray yellowish one are the tumors, and some of the cores would pass through the tumors and pick the tumors, whereas certain ones like the core number 1 did not pick the tumor, core number 6 would not have picked the tumor. So you would have these 12 cores, all may not contain tumors. Some of them may contain a lot of tumor and some may contain very less tumor. And that's the understanding about prostate cancer, that it's a multifocal tumor, and that's why you need to take so many samples from different areas so that you may pick up the cancer. So this is how the 12 cores arrive in the pathology lab, labeled with different zones. So this is left upper outer zone, and this is middle zone. So these 12 cores are separately contained, 12 different containers. And when you look under the microscope, when do you start suspecting? For the PG students, basic understanding is the prostate glands, the normal prostate glands are very convoluted. So they have this convoluted lumen like this, and the luminal aspect would be very convoluted. That larger glands with convoluted contours of the lumen would not make you think about prostate cancer. It's when you start seeing these rigid glands with very rigid lumen, smaller glands, which are seen between these normal. So this is a normal gland, this is a normal gland. But when you see these glands, you will start feeling under low power that there is something wrong. That's when you start suspecting that the patient probably has prostate cancer. When you see small rigid glands infiltrating between normal large glands, that's when you start thinking about prostate glands. If you have doubt, you would do immunohistochemistry. The classical markers are P63 and high molecular weight keratin, which should label the basal cells. So basal cell presence means that the glands are benign. Absence of basal cells, P63 and HMWCK, will make you suspect that and confirm that this is a prostate cancer. So in difficult cases, you would employ a P63 and high molecular weight keratin. Again, to show high molecular weight keratin, which is absent in the malignant glands and present in the normal glands in the adjacent core. You also would employ Amacar, which is a racemase stain, which stains the malignant gland circumferentially. If you look at it, the whole gland throughout is circumferentially positive for Amacar, and that's important to say that Amacar is positive in the gland. So absence of basal markers and presence of Amacar positivity would clinch the diagnosis of prostate cancer. Other important morphological features is presence of this wispy kind of intraluminal mucin, a very tinctorial characteristic of the stroma within the glands, malignant gland, which is called as mucinous fibroplasia. So these are malignant glands if you look at this, and the stroma, which is caught up in between these glands, gives a very shiny and pinkish appearance, collagenized kind of appearance, which is called as mucinous fibroplasia. A very, very important feature cytologically is the presence of very prominent nucleoli, almost 1/3 the size of the nuclei in prostate cancer foci, and perineural invasion, especially a circumferential perineural invasion, would be a sine qua non of a malignancy in prostate cancer. So this is a 12-core slide, 6 from the right side, 6 from the left, a pictorial and diagrammatic representation to show that there may be certain cores which have no tumor, where there will be certain cores which have tumor, and then you give something like this scoring like this, 3 plus 3, 6, or 3 plus 3, 3 plus 4, 7. So this is what we mean by Gleason scoring. So this is the Gleason scoring, which is important. It is important for the clinician for decision making, and we will in the subsequent slides understand and learn how this is important for scoring. So in 1966-67, Sir Donald Gleason, he developed this Gleason's grading based on the pattern of growth, the glandular, how the glands are arranged with respect to each other, whether they are separate, whether they are fused to each other, whether they are single, whether they are single cells, there are papillary structures. So based on the pattern of these glands, he created a grading system. This is the original photograph which I found from the internet. These are the diagrams which he draw astutely by looking at the tumors under the microscope. And if you look at it, these are very circumscribed nodules of glands. And as you go towards a higher direction or the poorer tumors, they become more fused and more single and more papillary in pattern as we go. So these are the diagrams which he made, and then he clubbed them into 1, 2, 3, 4, and 5. So there's another picture, rather hazy one. And that's how Gleason grading started. So this is a picture again to show that a circumscribed nodule of gland would be pattern 1, a more spread out but separate glands again would be pattern 2. The original Gleason showed that presence of cribriform and papillary would be pattern 3, but this has changed in the coming years, and I'll be alluding to it subsequently. And then you have different other patterns which were pattern 4 and pattern 5. So in 2005 and 2014, there were certain kind of amendments in these Gleason grading, and people sat together and they wanted to change certain ideas about Gleason scoring. And that's what happened in 2005 and 2014. Again, in 2019, we had 2 papers, one from the GUPS and one from the ISUP about this grading conference about consensus on this. So just briefly, what happened in 2005? So this is the original Gleason from 1966 to almost 2005. Everybody followed this. In 2005, they basically, what they did is they said all fused glands, all cribriform glands all poriform glands would be put in pattern 4. So earlier, the original Gleason said that cribriform glands and papillary kind of glands, fused glands, some of them would be part of pattern 3. But in 2005, they made it very, very clear that any cribriform gland, any fused gland or poriform gland should be a pattern 4. This is based on the fact that these behave worse compared to when the glands are single and separate. So a pattern 4 gland starts telling the clinician or the pathologist that something more is sinister in the patient. And that's why this is put in under pattern 4. So this is a picture. You can take a printout. This is from a Jonathan Epstein article. You can readily use it. You can see as long as the glands are single, separate, and you can draw a line around each gland. As long as you can draw around a line around each gland, you would put it in pattern 4, pattern 3. Pattern 4 basically means that the glands have started fusing. They have become poorly formed, and fusion and cribriforming, so that those are in pattern 4 glands. Whereas in pattern 5, it is solidness, necrosis, comedonecrosis pattern, solidness, very poorly formed glands, or you can't even make out any glandular lumina, and single cell pattern. So those are pattern 5 according to the Gleason. I think this picture really helps sometimes, but again, if you look at this picture and this picture may get confused. So Gleason scoring is not something which you can learn overnight. You have to put everything into perspective and then arrive at a Gleason score. So there are certain gray areas which will always remain in Gleason grading, but you should try and delineate these ones from these ones. So the pattern 3 has to be a sacrosanct kind of pattern, because these tumors behave very well compared to pattern 4 and pattern 5 tumors. So that's important. So again, the same thing, as long as there are separate non-fused glands, it's pattern 3. You have fused cribriform and poorly formed glands, it's pattern 4, and single cell Indian file pattern, no gland formation, solid comedonecrosis, all are pattern 5 or grade 5 tumors. So how is the Gleason scoring done? The Gleason scoring is done by adding the 2 patterns. And what are the 2 patterns which you need to add? It is the most predominant pattern and the highest grade pattern. Now, when you mean by highest grade, even a slight percentage of highest grade pattern should be added up to make the Gleason scoring. So most predominant and the highest pattern. So you should keep remembering these. And we'll allude to this. So what is the importance of Gleason grading? So if supposing you don't give a Gleason grading on prostate cancer, your clinician would call back and ask you, is it important? What value does it convey to the clinician? So it influences the treatment planning, it risk stratifies the patient, it helps in predicting the pathological stage of a radical prostatectomy, whether the tumor can have extra prostatic extension, lymph node metastasis, or seven. All these can be predictive based on several nomograms which are present, which are available. And you can even predict the biochemical failure based on the Gleason scoring. So that's very, very important. So as pathologists, you are in a very unique position to tell the clinician how the tumor is going to behave. And hence it's a very powerful prognosticator. So again, this is from the NCCN guideline 2021. If you look at the risk stratification group, all the risk stratification groups from very low, intermediate to very high groups all have got the Gleason scoring or the grade grouping system, which is part of this. So the initial risk stratification, when you give a Gleason score and the PSA levels are present, the patients are categorized into these risk categories, and based on that, further steps are taken for management based on the risk stratification. So it's a very, very important parameter which they use. And then there are different therapeutic options for the patients. The patients can either undergo surgery, they can undergo radiation, hormone therapy, surgery for as orchidectomy for metastatic. And this is a unique state where a low-grade prostate cancer, where a low Gleason score prostate cancer can be just followed up for several years and not undergo any kind of therapy. So that's an active surveillance which will come more and more in practice. And this is a unique opportunity where the pathologist is of great help to tell that there is a very, very indolent cancer in the patient, and this patient can go for active surveillance. So coming to just an example, supposing you have a core, this is a single core in which you have pattern 3 60%, a pattern 4 25%, and a pattern 5 15%. The original Gleason, the original Gleason scoring of 1966 would have scored it as 3 plus 4, the primary pattern and the second predominant pattern. Whereas the 2005, 14 and 14 modified Gleason would score it as 3 plus 5. So any highest pattern, even if it is 15%, even if it is 2%, if you can clearly identify a higher grade pattern, that has to be part of the Gleason scoring. So that's the basic difference and understanding between them. But there are certain problems with the original Gleason system. So the original Gleason system said that you could have scores like 2 plus 1 or 1 plus 1, because the scoring, the patterns range from 1 to 5. So till 1 to 5, you could have put in the patterns, and the scores would be 2 to 10. So that's the main issue which we had. In practice, what happens in a given core biopsy, you cannot see the circumscription. So the pattern 1 and pattern 2 were based on the circumscription of the nodule of the glands, which you cannot pick in a core biopsy. So in a core biopsy, the minimum pattern which you can pick is a pattern 3. And so the minimum score which you can get on a core biopsy is a Gleason score of 6. So we'll go on to this. So this was the problem with the original Gleason system. And then there is certain issues with the patient's understanding. So the major point which I need to convey is that grade 1 and pattern 2 should not be diagnosed on a biopsy core. The minimum you can diagnose on a biopsy core is a pattern 3, and hence the minimum score which can be given on a core biopsy is a Gleason score of 6. Now let us look at from a patient's perspective. Let us try and understand. If you tell a patient that your grade of the tumor is 6 in a range from 1 to 10 or 2 to 10 rather, the patient would feel that I'm sitting in somewhere in the middle of the spectrum. The patient feels that I have got a 6 out of 10 Gleason score. That means I am somewhere closer to my death, or I'm closer to being a more aggressive kind of cancer. But if you look at in practice and understand the concept in a core biopsy, 6 is the minimum score which you can diagnose on a core biopsy. So actually in practice and in practicality, this is the lowest score which you can give, and the lowest score a patient gets on a core biopsy from the pathologist. And this understanding helped us reshape the Gleason scoring according to the understanding of the patient. So patient needs to understand that 6 is the minimum score, and he may not need a treatment in this setting. There have been certain recent observations, not recent, this was in 2012, this paper, which showed that any Gleason score of 6 patient, if it was a pure Gleason 6 in the prostate, in the whole gland, the potential for metastasis is almost 0. So basically what they meant, they looked at 14,000 prostatectomies from several institutions, and then a pure Gleason 6, has hardly got any metastatic potential. So there is no metastatic potential for these tumors. So if a patient has a pure Gleason 6 tumor, a low volume tumor, the chances that he may not die of prostate cancer is very high. So that's the understanding. So then people had a debate. They wanted to know whether we should call 3+6 as cancer. But when we look at prostatectomies, we do understand that these are cancers because they lack basal layer. They have potential to locally invade into seminal vesicles and the periprostatic fat. So they indeed are cancers. And I think this debate is put to rest now. A 3+3/6 is a cancer, but it is a very, very indolent cancer. So the other understanding is somewhere the patient needs to have a true pattern 4, a good amount of pattern 4 to develop metastasis. So that is the understanding of Gleason scoring and pattern. And this is extremely important for pathologists to take it, because once you are at the crossroads between 3+3 and 3+4, I'll say significant 4, say couple of cores or 3 cores, positive 4, you should really spend more time on those patients, because they may be a deciding factor between active surveillance versus a radical prostatectomy. So you should understand that a pattern 4 is needed by the patient to develop metastatic potential. So in 2013, again, Dr. Epstein and several other people, they validated a new grading system on 20,000 patients from 5 academic institutions. This team had clinicians, urologists, pathologists, oncologists, radiation oncologists, and they also understood the value of pattern 4. And they said a patient who has got a lot of pattern 4 compared to pattern 3 will behave worse compared to a patient who has more pattern 3. So they split up this pattern, the total score of 7 into 4+3 and 3+4, and then they devised out this new grading system to better align and prognosticate the patient of prostate cancer. So this was the paper in 2014. And what they did was, they have now made this grade group system. So we have two understanding that Gleason 6 is the smallest or the lowest score which you can given in a core biopsy. So a patient of Gleason score is at the lowest end of the spectrum. He's not in the middle of the spectrum. He's at the lowest end of the treatable spectrum in the case of practicality of prostate cancer. And they called it grade group 1 because 1 means it is actually at the lowest. And then they split up 7 into 3+4 and 4+3 based on the prognostications that patient who has more of pattern 4 does worse compared to a patient who has more of pattern 3 in a score of 7. All score 8s were put in grade group 4 and all 9 and 10s were called as grade group 5. So this is currently what is being used. And when you report your prostate core biopsy, you have to give a Gleason score as well as grade group system in the current practice. So why are these groups done, and what are these groups? Are they really relevant to us, and what will in future happen to these groups? So like I said, these are prognostic grade groups. So when we mean grade group 1, grade group 2, grade group 3, we are actually telling the patient as well as the clinician that they are belonging to different prognostic groups as such. And this was based on a lot of Kaplan-Meier curves and recurrence survivals and survival curves. The grade group 1 patients do the best compared to 2, 3, 4, and 5. You can see out these plots on years of surgery versus a probability of recurrence over the years. So we come back to our 12 core biopsy, just some practical situations where we look at these 12 cores. So this is your 12 core. Again, there may be cores which have no tumor, but then there may be other which are 3+3, 6 and other scores. So this patient would be scored as Gleason 3+3 score 6 with a grade group 1 in your report. Another patient, he has got tumor in all the cores. You can see all 12 cores are involved. Many of them are 3+3, 6, but then there are certain which 3+4, 7, and then there are some which 4+3, 7. So here 4+3, 7 would be the highest. 3+5 would be the highest because there is one core which has got 3+5, and hence this patient would be a grade group 4 patient. So for treatment purposes, the clinician will take the core with the highest. So anything which is the highest core, that will be taken assigned as a Gleason maximum score to the patient while treating. Another one, here you have a lot of 3+3, 6, but then there are a couple of cores which are 4+4, 8, and hence again this patient would belong to a grade group 4 patient. Another one to show that there are a couple of cores which no tumor, some which are 3+3, 6, but then there are certain which 5+4, 9, and this patient would belong to a grade group 5 score of prognostic scoring. So like I said, we have already discussed this. The benefits is more active stratification. It is more patient aligned. and the patient understands that he belongs to a grade group 1 rather than a middle of the spectrum score 6. So these are certain good benefits of Gleason, and it is more aligned with the patient care. Some pictures to show. So these are few, again, very rigid looking glands. Luminal mucin is seen very nicely. So this is prostate cancer, and this is a Gleason 3+3 6. Again, to show some glands here are branching. So this is again a very well-formed gland which is branched. This would still fall into the category of Gleason 3. So again, 3+3 6, a grade group 1, that would be your report. Here you have started getting more hazy, more fused kind of glands here, some fused glands here. So there is some pattern 4 in this definitely at multiple foci, and this would make it 3+4 7 or grade group 2. Another picture to show very definite well-defined glands. You can draw lines around each gland. This is pattern 3. Whereas here you start seeing fusion, little fusion here, which you will put it in pattern 4. This is cribriform pattern 4. A word about cribriform pattern. You can see that these are large, complete glands with multiple punched out holes within them. So this is a cribriform pattern 4. And amongst all pattern 4s like fused glands and poorly formed glands, cribriform pattern 4 has got poorer outcome. So there are a lot of studies which are recently coming up from 2018, 2019, and last 2-3 years, which say that amongst all these pattern 4, cribriform pattern 4 is likely to behave more aggressively. So if there is this kind of cribriform pattern 4, I would definitely recommend, or the recommendation is that you put it in your report that cribriform pattern is present. Again, glomeruloid pattern are all pattern 4. They look like glomerulus and they should be mentioned in the report. Again, to show cribriform pattern 4. And then now you start seeing 5, you start seeing single cells here, lot of single cells here, indent filing pattern, which would be pattern 5. And then you have poorly formed and ill-formed glands, which would be pattern 4. So this Gleason scoring would be 4 + 5, 9, and the grade grouping would be grade group 5. Single cells, sometimes lymphocytes can be very, very majorly confused with single cell pattern of Gleason tumors, and sometimes you may have to resort to keratin stains and LCA to delineate them. Again, solid sheets, no gland formations, crushed morphology, perineural invasion is seen very well here. And this is again a Gleason score 5 + 5, 10, grade group 5 pattern. Again, single cells, no gland formation, pattern 5. Solid sheets, no lumen formation, no acinar pattern, again pattern 5. So these are some examples I've shown you. Sheets of cells, again grade group 5, 5 + 5, 10. So this brings us to another important aspect is the reporting of pattern 4. So you have a very well-formed glands, but then you start seeing very poorly formed and some fused glands here. This is definitely a cribriform kind of a gland. So here the maximum pattern is pattern 3, but then there is pattern 4. And in such situation, you have to give the amount of pattern 4. So supposing you have, say, 2 cores which are positive for tumor, the rest 10 cores are negative. And in these 2 cores, there is some pattern 4, but it is less than, say, 10% in both the cores. That patient may still not need a surgery. So basically, it means he's got very, very little pattern 4 somewhere, and that may not change his prognosis too much, and he may not require a surgery. So that's the importance of giving a pattern 4, percentage of pattern 4 in your report. So this is a rough diagram again to show that this is a core biopsy of this length, and around 30 to 40% is there of tumor which is in the tumor, or how much the tumor is present in the core of the biopsy. So I think this is a little too complicated to understand sometimes, but if you look at, these are different cores of tumors, but in all these cores, according to Epstein's method, he says if the tumor is present here and the tumor is present here and here, or it is present throughout the length, the amount of tumor involving the core is similar and should be reported. So this is 60%. If this is 60%, even this should be called as 60%. Some people don't believe in it, but most of the Western centers have started agreeing that as long as this focus and this focus look absolutely similar, they are probably belong to the same length of the tumor, and they're the same tumor which are there, and hence the totaling should be done. Am I audible? Hello.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
A quick concept about intraductal prostate cancer. No, not go into detail. This is a lecture in itself completely. These are basically neoplastic proliferation within the existing ducts. and they are most likely colonization of benign ducts by invasive cancer. And I'll show you an example. You have invasive prostate cancer here. These are the invasive prostate foci, but these very rounded looking foci, you are very tempted to call them as pattern 4 invasive cancer. But when you do, so this is again another picture to show that these look very rounded and they look cribriform papillary, and you may likely to call it a Gleason pattern 4. But when you do a P63 basal marker, you find that there is presence of basal marker all around the gland. So this is how an intraductal prostate cancer looks like. This is not an invasive, but it basically means that there is a tumor, invasive tumor, which is running through the ducts, running through benign ducts. That's why you still have the basal layer around it. It's a difficult concept to understand. The ISUP says you have to grade this. The GUP says that you should not be grading IDCP. And in the coming next 5-6 years, we will get more clarity on this. But what we know about intraductal prostate cancer is when you see this lot of intraductal prostate cancer, you have to understand that these patients have high volume disease and they have high state disease. So even if you feel that there is an organ confined tumor, in such cases, usually it's not a non-organ. So it's most likely that it has invaded the seminal vesicle or extra prostatic space has already been invaded when you have a lot of intraductal component. So the significance of intraductal prostate cancer is that it's a high volume and a high state disease in the patient. So that should be kept in mind. So the important practical point is, if you don't do a P63 in this case, you are going to call it invasive pattern 4. And in certain cases, you have to keep this in mind and be aware of the fact that this may be intraductal and you should employ P63 or HMWCK to pick up these basal cells and not call them as invasive foci. Again, pictures to show intraductal prostate cancer with P63 nicely highlighting the basal layers in this. So pure IDCP is not graded, and IDCP invasive predicts adverse outcome, and it has got a high stage and high volume disease in this. So basically that brings me to a very critical kind of a slide. What are the critical points when you reach the crossroads of reporting prostate? So in a 12 core biopsy, if you have 2 cores which are positive, you have to really struggle and you have to really put in a lot of time to clearly say how much is pattern 3, how much is pattern 4, and whether pattern 4 exists or not. So these are the 2 things out of 12 cores. If 2 or less than 2 cores are positive, your core percentage of tumor involvement is important. Your pattern 4 is important. How much pattern 4 is important. So those things are should be there in your report. Now we know that a 3+3/6 tumor, pure 3+3, should not have metastasis. So the point is, if you already know from the clinician that there is a metastatic prostate cancer with a lot of bone mets, if you are reporting all 12 cores as 3+3/6, you may be wrong. There's a theoretical possibility that you may be right, but it's very minuscule. We know that there should be a sizable proportion of pattern 4 or pattern 5 to cause the metastasis. And this is the model prostate biopsy report. So in your report, these are the things to be mentioned: conventional versus other types of prostate cancer like ductal. What is the Gleason score? What is the grade grouping? Number of involved cores, percentage of core involved. Some people even give the millimeter of core involvement. If there is a pattern 4, the percentage of pattern 4, especially when you are giving a score of 3+4, you should mention how much pattern 4 is present. Also mention how much is the cribriform pattern, whether it's a significant cribriform pattern, because those do worse. If IDCP is present, you should mention. LVI, PNI are standard. And then if you can see some adipose tissue with tumor in it, that makes it extra prostatic cancer. So these are the things which you can easily put it in your prostate core biopsy report. And mind you, each one of them really helps managing every patient by putting them into different risk stratifications. When it comes to radical prostatectomies, supposing you have a scenario like this, you have 2 nodules, one is a complete 3+3/6 and another is 4+4/8. In this scenario, you would have to separately say that there are 2 nodules and this would be the dominant nodule. The patient is likely to behave because of this throwing up a metastasis, because the chances of this throwing a metastasis is almost nil. So that is the understanding of a grade grouping and prostate Gleason scoring in a prostatectomy specimen. Again, another example, you have a 3+4 grade group tumor in a radical prostatectomy with very, very minor pattern of 4, that you would put it as a minor grade 5 or a tertiary pattern 5 in a radical prostatectomy. Obviously, in a radical prostate, you would want to give a lot of other parameters, whether the tumor is completely confined to the prostate, whether the margins are involved, whether there is extra prostatic extension. And based on the pathologist's report on a radical prostatectomy, the adjuvant radiation or hormonal therapy is instituted in such settings. A little about the future, because the talk is about from past to the future. There are going to be some advancements in prostate cancer diagnostics, some modifications in Gleason on morphology are likely possibility, and we will go through them. So if you look at this, we are currently doing truss-guided biopsies, but transperineal magnetic resonance imaging biopsies are going to come in big way in the next decade, because people have found that when you do a truss-guided biopsy, your needle goes obliquely into the prostate, and you are likely to miss anterior tumors. In the West, they have found that several anterior tumors are missed, and these patients present at late stage because they are missed early because of the rectal biopsies. If you do a perineal template guide biopsy like this, you put in core needles, you are likely that the anterior prostate tumor is not missed. So transperineal rectal biopsies would be coming up in a big way in the next decade. So what will happen to the groups? We have just discussed the grade grouping system. There are several authors which are challenging the maximum Gleason score versus a global Gleason score. So you have, supposing you have a hypothetical situation, only one core is 4 + 5 9, and the rest 11 cores are 3 + 3 6. Many say that the 3 + 3 6 should also be considered significant, and a global Gleason scoring is necessary. So that will be something which will come up in the future. The grade 4 is very heterogeneous. You have 5 + 3, 3 + 5, 4 + 5, and at the outset only you can understand that these don't look very similar in their prognostication. So they are going to probably change over the years. Again, the cribriform pattern is worse than other pattern 4s, and that would be the next change in the Gleason which will be coming up. Moving beyond a Gleason scoring, there are certain things which can get incorporated within the Gleason or as separate from Gleason is a stromogenic carcinoma. Now, time and again, people have looked at the stroma of the prostate cancer. Generally, prostate cancer does not have a desmoplastic stroma as you would see in breast or say cholangiocarcinomas. But slowly people have started realizing that there are certain these myxoid kind of stroma or little fibrogenic stroma which may be present, which are called as stromogenic carcinomas. So these may impact the outcome of the patient. So they are saying that it's not only a gland and the pattern, it is a stroma which will become important in the coming future. And there may be a stromal grading in the coming years which may get incorporated in prostate cancer. Again, the same thing to look at certain stromal infiltration markers, which say that they may have a lot of influence in coming years. Then there are rich array of biomarkers which will be coming up. I'll not go into the details. There are certain serum-based markers, urine-based markers, and tissue-based markers which may come into daily practice in the next decade to screen the prostate cancer, to diagnose prostate cancer, and as well as prognosticate prostate cancer. So these are just a picture to show how these markers may be there. So in the diagnosis, if you suspect diagnosis, there are these kind of markers, some of which are done on biopsies, some on blood, which can help you pick up which tumors, which are tumors and which are not tumors. And they may be done at initial biopsy or repeat biopsy. And then there are prognostic markers which will help you tell how the patient are going to behave. So this is again just genomic classifiers of early prostate cancer. So you have a low volume, low Gleason tumor. These Prolaris, Oncotypes, and Decipher are different tests which are available in the US, which will tell you whether this low grade Gleason cancer or low Gleason cancer is how it's going to behave based on certain genomic and genomic markers. I would like to add a word about neuroendocrine differentiation, which is coming up in a big way. So most high-grade prostate cancers would progress to become castrate resistant or androgen insensitive. So if you look at the management of prostate cancer, the patient, metastatic prostate cancer, they either undergo orchidectomy or they would undergo hormone injections because these are androgen dependent tumors. But a neuroendocrine prostate cancer like a small cell carcinoma is totally androgen independent, and they have different mechanisms to become independent. They amplify the androgen receptors. The androgen receptors get mutated in them, and they circumvent the cycle of this and develop a neuroendocrine phenotype, and they run away from the androgen pathway. So that will come in a big way, and you will see more and more small cell carcinomas and large cell neuroendocrine carcinomas, because many of the conventional prostate cancers are being treated by androgen inhibitors. And after some time, these androgen sensitive prostate cancers slowly change their phenotype and become small cell cancers or large cell neuroendocrine cancers. Some quick notes on prostate cancer treatment. PARP inhibitors would come up, and it is now known that prostate cancer, about 5 to 8% would harbor BRCA1, BRCA2 mutations and homologous recombination or DNA defects, which would make them amenable to BRCA inhibitors, just like breast and ovarian cancers. So this is going to come, and it is known that BRCA mutated tumors have higher risk of metastasis as well as aggressive behavior. So I think I'll not go into the details of this. Another thing which as pathologists we would hear more and more is the presence of this androgen receptor V7 variant, which causes resistance to the standard treatment now of abiraterone and enzalutamide. And I will not go into these details. And it is now seen that P10 loss on a biopsy, if you do a P10 and it is lost, those patients have poor outcomes when they're treated with abiraterone. This slide I have borrowed from Dr. Amit Joshi, one of my medical oncologists. And so this can be done on a core biopsy. So if you do P10 and P10 is lost, you can say that this patient may not respond to drugs like abiraterone. PD-L1 inhibition, like all other tumors in the body, you will do an MSI or MMR protein, and if these are deficient for MMR, these patients are amenable to PD-L1 inhibition. And you can see the graphs, they do wonderfully. The problem again is the cost of pembrolizumab and PD-L1 therapy, which is exorbitant at the current situation. Now, another situation which is developing in prostate cancer is the presence of deep learning and automated learning and AI. So when you read such papers, you really think that you're going to lose your job and you are going to press your panic button, and you get worried whether this is going to completely overwhelm the pathologists, and we have AI everywhere. The clinicians start using AI. So will we lose our job? The current status is that several institutes in the US have started using algorithms and AI for Gleason scoring, and you can see out how they map out these tumorous areas and non-tumorous areas can be mapped out, and they are pretty good at doing. So the deep learning systems currently have almost as good experience as almost a 15-year-old pathologist who is in the field. So this is coming up, but the understanding and the thinking about AI is that it is going to help us, just like molecular is helping us, just like immunohistochemistry is helping us. AI is going to help us do our work more efficiently, more faster. The run-of-the-mill cases would be seen by AI, and you will be able to sign them out quickly. But you would be needed to give your expert opinion. And as such, we don't look that we will lose our jobs. So coming to my final slides, medicine is not maths in prostate cancer. You have to remember 3 + 3 is grade group 1, 3 + 4 is 2, 4 + 3, and so on and so forth. So that's the basic understanding of prostate cancer. So to summarize, Gleason grading has come a long way in the last 50 years. Grade groups and Gleason grading may be further refined, especially the cribiform and IDCP may get incorporated. Biopsy techniques are going to going to evolve over coming in the coming years. Stromal features, molecular testing, and artificial intelligence are all going to slowly getting integrated in our day-to-day practice, and we will have to have no choice but to embrace all of them in the coming years. So I would end by saying that there is a surgeon behind treatment, there is a radiation oncologist and medical oncologist all treating the prostate cancer patient, but somewhere there is a pathologist behind a microscope looking carefully at the slides, looking carefully to make out the Gleason scoring, which is absolutely essential for risk stratification and management of patients. Would like to acknowledge Dr. Desai, my head and colleague in urology, my UroDMG colleagues and residents and technical staff and patients with from whom we learn the most of our things. Thank you so much.
Thank you, sir, for a very informative lecture. So can we take up a few questions?
Yeah, sure. That's why I finished in 40 minutes.
So the first question, do you recommend reporting of length of involved pores?
Yes. So length in the sense I personally do not give the total length of the core in millimeters. Not unless somebody is really asked me to do that. I would give rough percentage of tumors. So that's important. I'll have to admit one major thing in a difference between, say, a peripheral area and tertiary referral centers. We get very high-grade cancers, and we get tumors in which almost all 12 cores are positive. So there, the percentage of core becomes very unimportant, I would say. So if all your 12 cores are involved by a Gleason 9 or 10, then the percentage of 9 and percentage of 4 and 5 doesn't make sense in that. That's not practical. The percentage is important at the lower end of spectrum. You have 1 core positive, 2 core positive out of 12 cores. The Gleason scoring is 3 + 3, 6, 3 + 4, 7, 4 + 3. There you have to be very specific and careful about the length of core involved, percentage of core involved, percentage of pattern 4, because that may really make a difference in the management of patient. Especially these are elderly patients, they have comorbidities. So to do extensive surgery in them is always a question, whether to put them on hormones, to do an orchidectomy for these patients, metastatic. Those are the questions which come into day-to-day practice. So it's not only Gleason, it's a multifactorial thing which you have to put into practice.
Sir, how precisely can we predict the metastatic role based on Gleason score?
We cannot. So there are nomograms, Dr. Vivek. You will have to go to the internet, and there are several tables. Like I said, it's not only based on Gleason. So if you say that the Gleason score is 4, pattern 4 plus 3 versus 3 plus 4, there are tables which will tell you what is the metastatic potential of these patients. But in a given practice and in a given patient, these nomograms may not help. It is just based on several studies over several groups and a lot of statistical analysis that they come up with these nomograms. And that's generally not a part of a day-to-day practice to start predicting each other. So they know that a Gleason 4 plus 5, 9 with a high volume tumor and a high PSA is already probably a metastatic tumor at presentation.
So the next question is, what is the status of AI in CA prostate reporting in India?
AI. So I think currently nobody is actually using it in day-to-day practice algorithms. There are several. So we also have some tie-ups with some companies as well as something. We are trying to validate different algorithms. And we have tie-ups with some people in US also who are trying to study these different programs. You have to understand one thing, Dr. Vivek, just as we have, say, thousands of pathologists giving thousands of Gleason score, finally, at the end of the day, we are going to have thousands of software and AI algorithms that are going to give different Gleason score and Gleason thing. So we will have a problem of plenty of AIs, and the clinician will be again as confused as.
60,000.
Yeah.
Pile around me.
Yeah. More questions?
So that's it. Questions.
I can see a couple of questions. I think Dr. Manoj Kahar has said that there is sometimes there may be dense inflammation, extremely difficult to distinguish from pattern 5. So we do, it says Dr. Manoj, we would do, if in a difficult case, I'm not able to say whether it's really inflammation versus a pattern 5, especially in a case where it makes a difference. I would do LCA and cytokeratin. I think this is a direct message which has come to me, Dr. Vivek.
Okay.
So I would do an LCA and CK in these cases. Dr. Sunita has asked, do you report presence of colonic tissue? I really don't know whether it's of any significance, Dr. Sunita, but in a core, which is supposed to show prostate core, but not showing a prostate core and only colonic tissue, I would say that this core shows only colonic tissue. But otherwise, in the presence of tumor, adding or the presence or absence of colonic tissue doesn't matter, unless until you can see it directly invading it. Ritu has asked me how to differentiate a Gleason SNR4 versus ductal in a core. Ritu, it's extremely difficult. A ductal by definition looks ductal in the sense it looks like a colonic adenoma. I don't do much more colonic biopsies these days. You may be seeing more. So anything which looks like a colonic adenoma on a prostate core biopsy, and you're sure that's a prostate cancer, you have to call it a ductal pattern. So in a core biopsy, you don't put a bottom line that it's a ductal carcinoma. You say it's a prostate carcinoma with ductal pattern. Ductal carcinoma is diagnosed generally only on a radical prostatectomy specimen. Dr. Sadaf Hayat has said that how far NKX3 will help in malignity. I find NKX 3.1 an extremely useful marker, extremely helpful marker for a prostate. And in difficult cases, especially when I have to distinguish between a urothelial and a prostate, I regularly employ NKX 3.1. It does not help in distinguishing benign from malignant. NKX is a marker of prostate, and even the benign glands are positive for NKX 3.1. Dr. Rajan Bindu has said, should we grade small cell or neuroendocrine? Small cell, definitely not. It is not, a Gleason scoring is not done for small cell carcinoma. Now, the question of neuroendocrine carcinoma is, if the neuroendocrine carcinoma is as a marker positivity of synaptophysin chromograin in a conventional prostate cancer, you would grade the conventional prostate. So your bottom line would be conventional prostatic adenocarcinoma, Gleason score 3 plus 4, 6 with 10%, 20% neuroendocrine based on your markers. But a small cell carcinoma pure would not be graded. So Shubha Bhatt is asking me, what is the global score? So Shubha, that's another controversial issue. Like I said, if you have 12 cores and only one out of the 12 cores is positive for say 4+5 Gleason, the rest are 3+3, 6, then you would really have to struggle. You would have to say that the global score probably includes pattern 3. Now, the maximum Gleason score in such a patient would be 4+5, 9. But if 11 out of 12 cores are showing 3+3, 6, and only one is showing 4+5, 9, then many people advocate that you should say that the global score is 3+5 or 3+4 sometimes in those cases. So that's how it is calculated. There are several other methods people use, but I generally don't use. At least the clinicians at my end at TMH would go by the highest Gleason pattern. There are several other questions as direct messages. Perineal invasion on Gleason scoring, any impact? So Bharani Dharan has asked me this question. The impact is only, Bharani, that perineal invasion, people say that it's got prognostic implication on presence of extra prostatic extension. So a tumor which has 12 cores and out of them several cores are showing a lot of perineal invasion, the chances that this perineal invasion is may cause extra prostatic extension and prostatectomy is more. The other important thing is if the peripheral cores, especially the posterolateral cores, are showing perineal, the chances that the neurovascular bundle is involved is very high, and they would not do a nerve sparing prostatectomy on these patients. Is AI-based reporting approved? Yes, AI-based reporting is approved in certain centers. I think a couple of centers in Pittsburgh are using AI-based reporting. So in the morning when the pathologist comes, the AI has already scanned the slides. They would mark the slides. They would say, these are the 4 out of 10 slides which are showing tumor, and you need to quickly go through them and form your opinion. So AI helps in sifting out the clear-cut tumors versus no tumors. It helps in sifting out the slides and prepare your work list. So it helps you in a lot. So hopefully in coming years, we would also be using some point of AI in our work. Somebody has asked me, is IDCP same as PIN? Nandini, PIN is a pre-malignant condition. IDCP in 99% of the cases is already a cancer which is running through the ducts. So you already have cancer somewhere invasive, which is running through the ducts, which has still have got basal layer, is an IDCP, whereas PIN is a pre-malignant condition. I think that answers most of the questions in the chat box. I think hopefully my lecture has been a little helpful, Dr. Anand.
Yes, sir.
Yes. Sir, I don't know whether sir was listening or not.
Yes, sir, it was a very wonderful lecture. I'm sure.
But I'm an anatomist and I was listening right through. Wonderful.
Great, sir. Great.
Very nice.
Now I request Dr. Anand Bhosle, sir, head of the department, to give the concluding remarks. Sir, please.
Good afternoon, everyone. It has been an honor to be a part of this wonderful guest lecture. On behalf of SMCW and SOHRC, I would like to extend my heartfelt gratitude to our esteemed speaker, Dr. Santosh Menon, sir, Professor of Pathology, Tata Memorial Hospital, Mumbai. And sincere thanks to respected Honorable our Dean, sir, and our senior mentor, Professor Dr. Bindu, sir, and a wide range of applause. And thanks to all participants who made the guest lecture a memorable one. And finally, I would like to thank our faculty members of Department of Pathology, the team Pathology of Pathology Department, and IT team members present here. Once again, thank you all. Before finishing, I will request Dr. Bindu, sir, you want to give some remark to Santosh Menon, sir. Dr. Bindu, sir, is our senior professor from our department. Dr. Bindu, sir. Am I audible? Bindu, sir. I think he's not in the list.
He's probably not, yeah. Yeah, I would like to thank you, Dr. Anand, for having me here. And I would like to thank all the participants. They have asked several questions, and I'm really happy. At the end of the lecture, if you have several questions, that means you have involved the people a little bit, and that's a plus point.
160 participants joined in the last peak. After this last 20 minutes.
Saturday afternoon, we have 160. So that's 160
a good. Actually, registration we got 900. But
okay.
160 joined, and once again, thank you. It was very informative lecture, and a request from our team Pathology and Symbiosis that we are inviting you as a faculty guest speaker in the MapCon
Sure.
2022 July.
Okay.
Is that the
Sure,
date
sure,
and
Dr.
that
Bhaskar.
we will inform you at earliest.
Yeah,
Thank
we'll
you
meet
once
you in
again,
person.
sir. Thank you.
Yeah,
Sir. Thank
yeah. Thank you so much. Thank you. Bye-bye, everyone. Bye-bye.
Bye.
Thank you.
The recording has stopped.